Okay, I'm here with NYC Pain MD again, and I'm here with Dave, and we've gotten such a great response talking to these guys there. They're doing great work with knee pain, shoulder pain, hip pain, ankle pain, back pain, all kinds of stuff. And they're doing a lot of regenerative medicine stuff, stem cell, viscosupplementation, PRP, all kinds of stuff. So we're going to get into some great stuff. Today, we're going to talk about the pros and cons of knee replacement. And specifically, we're going to talk about the one thing you should do before you get one. Make sure you listen to this. And what are some alternative treatments? And if you've had a knee replacement already and you still have pain, what are your options? So let's start out, because I'm making this call today interview because I just read an article and it stated that up to 1/3 of knee replacements are unnecessary. And there was complications and there was this and that. So I wanted to get someone here who really knew about this stuff, the ins and the outs, to give you guys the accurate information here. So what's the deal with that, with
Right.
the knee replacements?
Yeah, there's been a whole bunch of articles, and even WebMD has one. And so the varying articles, and by the way, guys, before we go forward, I'm a patient care coordinator. I take a lot of pride in making sure patients are educated properly. We're not here to give anybody advice. This is not medical advice. This is just to get you thinking and making sure you weigh all your options appropriately. And one thing about knee replacement is that the orthopedic surgeons, they are skilled. They do a wonderful job. However, I think patients just don't understand all the issues involved. And it is a surgery. And so, but with the 34%ers, they're thinking that 1/3 or up to 50% may be unnecessary to start with. It's a little controversial, but then again, not really. They're doing them on people younger and younger that may have mild to moderate osteoarthritis and mild to modest impairments. People are probably jumping the gun forward. And, it's not like your knee's like a Lego toy. It's not just snapped together. To familiarize you just a little bit, if you get a full knee replacement, you get about a 6-inch cut, or they're going to open up your knee about 6 inches, 3 inches below and above your kneecap. They have to kind of open it up. They then have to basically saw off the top of your lower bone called the tibia, your upper bone called the femur, and they have to pull the kneecap aside. They then saw off the tip of it. They have to put in a spacer. They have to put everything back together and sew it up. So this is major surgery. And we'll talk about the complications in a little bit. But there's a lot of talk about it. And again, on WebMD and many of the major sources, that a good 30, 40, even 50% may be unnecessary to start, which frankly is a little bit alarming. And so, of course, we're going to get into what are the options and what can you do if you've had a knee replacement and you're not happy and so forth. But one of the things that I just wanted to move to is a lot of patients feel that maybe they believe a knee replacement's their only option. And they think they've tried everything else, but the truth is they probably haven't. And there's a lot of studies that show there's other issues and other ways to go to relieve your knee pain. So that's kind of a good start point to wake everybody up and get them to understand there's options, and that, it is perhaps, well, we're not a surgical group, and I'm not a surgeon. I'm not even one of the trained physicians at our facility. There's a lot of issues around knee replacement that patients are clearly unaware of.
Yeah, I think a big thing here is that sometimes if you hammer, everything looks like a nail, and you get into that stuff, and there's a lot of new stuff. There's a lot of cutting edge stuff out there. Stem cell, viscosupplementation, PRP, and there's a lot of treatments that can help these knees. And the other issue is, once you have the knee replacement, you don't go back from that. Like as you described, it's a surgery. It's a big one, and some people need this, of course, but it's really worth looking into your other options first. And I mean, like you said, the biggest thing here is most people, they just don't know their options. And that's what we're going to talk about today. We're going to bring them the options, especially what the one thing these people should do before they get the replacement. And you're going to talk about that too. But what else would you like to talk about today?
Well, so and we'll talk about what we believe patients should do before they have a knee replacement. And again, I want to emphasize, knee replacement may be the best option for you in some cases. Some patients, they just get overwhelmed, and their friend had a knee replacement and did okay, so all of a sudden they think it's this little minor thing. But clearly, you have to understand it is not a minor thing, and we should talk about some of the issues you do have to be concerned with. Probably 2% of the cases have issues like infection risk, a risk from the anesthesia, a loosening or problems after, which can lead to a revision surgery. Now, revision surgery is really a whole new surgery, and that's even higher risk because you could have had bone loss. And there's some patients, and here's an interesting thing. A study with 272 patients were sent a questionnaire, and between 12 and 16 months after their surgery, 107 had responded, and of them, 40% reported they still had persisting pain after 1 year or more after a knee replacement. Kind of staggering. And the pain was not just minor. Using the visual analog scale of 0 to 10, 10 being the worst, they said their pain was as high as a 5 out of 10. So they, after all that surgery, they may have been a little better, but they still had a pretty significant amount of pain. So I don't know. I wouldn't consider that worthwhile for a surgery unless there were other issues involved. And so this may not be much different than the amount of pain you had before. Now, some studies show that the pain rates and percentages following knee replacements are going even after 4 years, 5 years, even longer. So even if your pain, if it were you or your mom or dad or a friend, if your pain is at a 6 or 7 or 8 or even a 9 out of 10, are you willing to go through surgery to get down, 3 or 4 points to get down to a 5? Here's another interesting thing. It seems that younger and more active patients, that a whopping 15% of their knee replacements are only lasting 5 years, which is, I didn't even know this one. I was doing research for our DAT today, and I was a little bit blown away by that. I just have to throw in one more. There was a French study that looked at 2,000 knee replacement patients about a year after their surgery. Now, of course, they do a nationalized healthcare system, et cetera, so they track this pretty well. And a very surprising 40% of the patients were taking analgesic pain medication about a year after their knee replacement. They were still taking medications for their pain. And 9% of those patients needed nerve drugs and even new narcotic drugs. So it just seems that younger and younger patients seem to have more pain before after their surgery was done, and continue to need more drugs. So these are really, really interesting, and we want to make sure that you understand that knee replacement may be not what you expect, the panacea. It's not like your native natural knee, and these are the issues. And again, let's say this: sometimes it is the best option, but I think you should know all this stuff going in. Another interesting fact, one more little tidbit, is that 87% of the patients that had knee pain develop, and it was within 5 years after their surgery. So it's not that something comes 20 years down when a knee replacement wears out, which is another whole issue with that patients have to understand. So I think those are some of the things that I'd like to bring to the forefront. And the patient should go into a knee surgery if they're told they need knee replacement. They have to understand that these are some of the things that they have to deal with. Here's one other thing: 1 in 400 patients may actually die from the knee replacement. That's considering the anesthesia risk and so on and so forth. So there is some risk involved in knee replacement.
Yeah, I think that's a huge thing, especially what you said about the fact that the knee replacements wear out. I've been told a lot of times that I'm not going to try viscosupplementation or stem cell or these other things because eventually I'm going to need the replacement, so I might as well get it now. And that's probably not the right attitude to have, correct?
I would agree. Yes, correct.
Because I mean, if if you're 55 years old right now, putting off the replacement, where if you could have another treatment where you could be relatively pain-free or reduce your pain enough that you could do the things you like to do, and you could do that for another 15 years before you needed the replacement, that might mean you only get one, as opposed to you might have to go through two.
Right.
And the second one's probably a much bigger ordeal than the first one.
Well, of course, the second one is really a revision, and revision surgery is apparently much more complicated. But that's an excellent point. And I know it was talked about on a prior webinar that you did, where it was discussed. There was a great retrospective study where an orthopedic surgeon took stage 4 bone-to-bone patients, and rather than getting a knee replacement, he offered them to go on image-guided viscosupplementation, which is one of the treatments that's very popular and effective. And he found that when they went back, that 82% of those patients still had not needed knee replacement 4 years later. Now, I'd love to see another follow-up, and it's probably quite a few years from that study being done. But here's an orthopedic surgeon who did a study, gave people a different treatment than knee replacement, and that treatment actually kept them pretty comfortable and moving. 82% of them still had not needed knee replacement. There's another recent study, I'll have to pull it up for you at a different time, that showed that roughly the same thing, 4 to 5 patients 5 years later still had not needed knee replacement surgery. So these things have actually been tested and studied. And so I think the overview on that is that there's many things that could be discussed and considered prior to, undergoing the knife.
What are some of these treatments people should look into before they get a knee replacement?
Right. So regardless, going back to that study, those were stage 4. Many of the patients that come in and see us, they're stage 2 or stage 3. That's called the Kellgren-Lawrence scale. And, essentially that's modest wear and tear. But even if they have severe wear and tear, one of the first things that's considered is what's called image-guided viscosupplementation. This has been talked about before on webinars. And basically, your knee needs oil like an automobile. And most osteoarthritis occurs from drying out of the knee or a shoulder or a hip, and we do those too. So basically, the docs put your knee in under a very advanced medical camera. This is called digital imaging fluoroscopy. We created a moniker called precision arthritis targeting technique, where they very precisely, and this is very important because the knee joint is narrowed and it's not so easy to get in there accurately on a blind basis. They put you through a series of virtually painless procedures where they apply an injection, and a syringe is filled with an FDA-approved lubricant called the Viscosupplement. There's several formulas that are used in our office. This has been very successful for a high number of patients. Again, that study I referred to of viscosupplementation was the treatment done under guided imaging, and about 4 out of 5, were able to seriously delay and hopefully completely avoid knee replacement. But some of the other interesting things we brought on board is something called lipogems, or fat-based aspirate, where we take regenerative cells, stem cells that come off of fat cells, and those are applied to that knee joint. And the theory is that these are like medicinal signaling cells. They go and target the damage. There's a guy named Dr. Eckhart Alt who's basically done before and after studies with fat-based stem cells and found that there is actually some regrowth of cartilage and hopefully the same cells that produce lubricant. Other procedures include the use of your own platelets. We do a special procedure called M-Site, and the M-Site really gives you a super pure concentrate of platelets. And the platelets are those things that heal you. If you cut your arm, what stops the bleeding are platelets. So in other words, these have healing factors and growth factors. Sometimes the combination of the platelets and the fat-based stem cells can do a great job in rehabilitating a really damaged joint and knee, and should be considered and talked about before for knee replacement. And then there's the issue of, well, I had a knee replacement and man, I'm still hurting. What do I do now? I don't want another knee surgery. And again, this is the small percentage of patients that are really still suffering after that knee replacement. And there is a special procedure called the genicular knee block. much like a nerve block for your back when it's inflamed, the nerves in your neck. You can actually do a procedure where you don't go into the knee because you can't inject into a knee replacement, but you can block the nerve pain by injecting it with anesthetic agents, and then you can actually do what they call a radio frequency treatment. And there was a study done out of an Indian medical journal that found some people, the pain relief is up to 4 years in painful post knee replacement knees. And it can also be done in painful hips and shoulders too, and as well as backs. So these are some of the options that can be discussed and should definitely be looked into before you jump the gun on a knee replacement.
So we're looking at, depending on the stage, depending on the problem, of course, we're looking at viscosupplementation, which is a gel injection, commonly known, and then you're looking at lipogems, which is a stem cell based procedure where they take the mesenchymal stem cells from your own fat, where they do a little liposuction and they take your own fat out. They do a procedure and they separate the mesenchymal stem cells from this fat, and then they inject it back into the site, and the stem cells have the ability to start to heal. So those are the two procedures that are pretty big. And then you mentioned the platelets there too. And after you've already had the replacement, and if you still have pain, the genicular knee block is a possibility where you mentioned a study that said that patients sometimes up to 4 years pain-free after that procedure, correct?
Right. And of course, as always, every patient is completely individual. Responses are individualized. Not everybody responds. Once one of our doctors feel they might be a candidate for any one of these things. But from my standpoint, if it's me or an elderly parent, these are things that want to be thought about before, the risks of surgery. One other thing I didn't mention, I think this is really important, and we have an office full of people right now, so I only have a few more minutes with this, and this is a fantastic talk we're doing, is I don't think people realize how much rehabilitation is necessary after a knee replacement or other joint replacement. It's sometimes months and months on end of grueling rehab, constant physical therapy to keep that knee replacement loose, constant working on it, constant aftercare. It's not like a Lego toy. You're not just popping that knee in. It's not like set it and forget it, like that famous infomercial. So again, but this is not to deter you from doing a knee replacement. If that's what you need, then, and that's the only option. If you've tried all the things that we've talked about here today, and you just cannot get any progress, and you are in serious, serious pain, then a knee replacement is worth, considering and perhaps going through with. But I think until then, from our standpoint, and I think from anybody's standpoint, these other things are surely worth considering. Now, you asked me at the beginning what the one thing is you should do. And the one thing we should do is this. We have a wonderful special program that we do offer patients that have knee pain, and it could be hip pain or shoulder pain or back pain. And we actually allow patients to come in at no cost and talk to one of our expert docs. Again, there is no cost to this. It's a complete community type service. The patients will be evaluated. The docs may even take an x-ray if necessary. They're going to ask each patient a lot of questions and find out where they're at. And they're going to answer all the patient's questions, as I said, and then the patient can decide. There's no obligation. It's stress-free. The patient can decide how they'd like to proceed from there. But it's a great opportunity to hear about the options, see if you might be considered a candidate. Not everyone is. And, weigh your options at that point, and the docs can explain everything in detail. If you still feel you want a knee replacement after all that and you're not interested, of course, that's fine. But it is certainly a worthwhile, and it's a great thing, and the patients really, really like it, by the way. So, and I know that you're going to post a special phone number where they can call. Once that's up, if you'd like to call, you certainly can set an appointment for that screening. You can ask the phone coordinator to send you a package of information, however you'd like to do it. But this would be our best recommendation. And that is the first thing that you should definitely do before considering, knee replacement and other surgical options.
And I would like to say here too, I just spoke to a doctor a couple days ago, a webinar we did. And I talked to him about this, and I went to a dentist not too long ago, a couple years ago, and I went in there, and it was like I went to a used salesman. I mean, a used car salesman. I went through this, and he showed, we did the examination and stuff, and then I went to this room, and a hired gun closer came in, and she had a clipboard. And she went through this really hard closing me, trying to get me to buy all kinds of stuff and high price plans and stuff. And I honestly, I was kind of shocked. I lost trust, and I was ready to start care with this dentist, and I walked out. And you guys aren't like that, correct?
There's nothing even remotely like that in our office. First of all, there's a lot of patients that we tell them, we don't even want you to decide today. Go home, talk to your husband, your wife, your daughter, your son, your family. Explain what we told them. Have them come in. Take them a packet of info. Of course, if they decide they'd like to move into a program with us right away, that's fine. But normally, someone that's not ready to move forward, that's fine. We encourage you to think about it. We give you all the information you need. We also have all sorts of varying payment options. Oftentimes we can get a lot of insurance to cover you, and we want to make it as stress-free and cost-friendly as possible, of course. But I think before worrying about all that, you need to feel comfortable that we're a very busy office. We don't even nudge. I wouldn't say we don't even nudge people towards care. We just give them the information, and they are free to proceed exactly as they'd like. And there are many patients that do that. There are some patients that come in, they hear their options, and they'll say, I'm going to get a knee replacement anyway. That's what I'd like to do. That's their decision. That's a decision. It's a patient-centered office. And that's the way we kind of handle things. So, gee, I'm sorry for that experience that you had. And that sounds a little bit uncomfortable.
Yeah, it is what it is, and sometimes doctors turn into salesmen, and that's a shame. You guys so busy there. There's no sales at all. You're going to come in, and this evaluation really isn't just about, am I going to start care there or not? It's about you're going to find out some great information. They're going to sit you down, and they're going to take a look at you, and they're going to say, hey, this is where we think you are. This is the best route for you. Here's some other options. What do you want to do? And you're going to walk out of there that day knowing what's wrong with you and what the possibilities are. And just that alone is like an albatross lifted off your neck. You know what I mean?
Right.
You can feel that, a relief of knowing what exactly is wrong with you and what can be done.
Yeah, I think that was well said. You're going to breathe a sigh of relief. Some options. You can put some thought in, and you decide to move from there. So, unfortunately, we have an office jammed with people now. I got to go chat with a few people. I think you can think of your individualized evaluation as kind of a personalized webinar, but in regard to your personal needs and your personal situation. But you're going to go ahead and put that number up. So if you're listening to this, you want to call for more information, just get an information package sent to you, that's fine. We can email things, we can mail things, but you certainly are welcome to set up that no-cost screening evaluation, and we'll go from there. And then hopefully next time we'll talk more about some other great things we're doing in the office.
Yeah, and we're doing these talks about once a week, sometimes twice a week. Correct. So if you guys interested, subscribe to the YouTube and hit the alert, hit the notification alert button. And so when we put up the video, you guys will get the alert. So you guys don't miss anything. So,
all right, good enough. And I'm going to run and talk to some patients, and we'll talk again next week.
The patients are yelling. So
all right, yeah, thanks.
Bye-bye.
All right, talk to you later. Bye-bye.